It is just a huge honor for me today to be podcast interviewing Bruce J. Crispin, DDS, MS, AAACD. He is one of the only dentists in the world that is both a diplomat of the American Board of Prosthodontics and an accredited member of the American Academy of Cosmetic Dentistry. He has been an international educator for over 40 years and founded the UCLA Center for Aesthetic Dentistry in the late 80s and Aesthetic Professional Dental Education Center in the 90s. His focus in education is creating comprehensive, hands-on, and clinical programs that are the highest quality and exceptional value. In 1997, a university professor had a dream of creating a unique, world-class dental facility. This facility's focus would be clinical and hands-on training for dentists in a rapidly changing dental market. A quality, communication-oriented aesthetic laboratory was also developed to support clinical training and assist alumni in their practices. Finally, a consultation service was implemented to assist alumni and lab clients tackle demanding treatment plans or prosthesis designs. While manufacturer support was necessary to provide state-of-the-art materials and technology, no exclusive deals were granted to manufacturers, thus allowing course content to remain unbiased. Original expectations for development were achieved in the first few years, and aesthetic professionals has become more and more than was ever envisioned. Over the last 10 years, aesthetic professionals has evolved from a 1,000 square foot facility with 2 employees into a 16,000 square foot facility with 30 employees and over 18 faculty members. The Education Center has 3 hands-on training theaters and 20 dental operatories for clinical training. A unique training center was also developed for the entire dental team to learn the many new computer-driven technologies. The Laboratory of Aesthetic Professionals has skilled ceramists, the finest technologies, including microscopes at every bench, and a great support team. In addition, the only finest materials are used, and supervision is provided. I got to tell you, I graduated in 87, and the first guy that 10x'd me was the man we're talking to right now. I mean, you have been a legend for 40 years, which means you have to be, what, over 51 years old now? If you've been doing... But Bruce, I mean, for me, it was love at first sight lecture for you. I was trying to get my FAGD and my MAGD, and you'd hear all this conflicting stuff. But, you know, they always say the sign of a genius is someone who can explain it to a 6th grader. And you could actually go beyond that and explain it to me, and which means you really had to know your materials were. I have so many questions I want to ask you. So just a little house cleaning. My homies, a quarter of them are still in dental school, and the rest are all under 30. I always say, send me an email, howard@dentaltown.com, and it usually comes from a dental kindergarten school. So you're probably not talking to anyone 31 years old, so I want you, so they got out of school, and if you look at the insurance, if you look at 100 million claims, it's almost all done on 4 6-year molars. I mean, what tooth most likely to have an MOD, a crown, a root canal, an implant? So she's out of school. She's trying to learn her basics for 3 or 4 years and then get into her own practice. So I'm going to abuse you as good as I can and just go through the list. What does she need to know about ceramic veneers?
Well, that's a good question because we do a 3-day course on it. You wanted me to tell you in about 5 minutes. Let me just add one little thing to our business that maybe you didn't cover. We also have a distribution center. So we sell CAD/CAM equipment, scanners, printers, all that kind of stuff. So in our lab, we also have all that technology and also in our school.
Is that at the website aestheticprofessionals.com?
Yeah, it is. It's called our distribution center. So we sell a lot of CAD/CAM equipment and CAD/CAM materials and so forth. So that's also part of our operation now. My son actually started that, Chad.
Okay, I'm trying. So dental practice lab distribute. I'm trying to find the highlight for it. The click thing.
Oh.
Okay, distribution. So you have education, laboratory, distribution, and practice. So distribution, you're selling these materials.
So we use them and sell them.
All right.
We pretty much know what we like and use. So
just stop.
Anyway,
I want to go back there for a second. So you basically have four. So you have the education, and it's hands-on, over the shoulder. Is it also online?
We have some. We have some webinars. We're kind of just getting, my focus is hands-on and clinical. And so.
Because my best marketing idea for you, if you got a great hands-on course, do a 1-hour online CE course on Dental Town. That's what Panky's been doing. Dawson's been doing. To try to get this kid to commit for a week, they put like a 1-hour summary of the week, and it converts a lot to go. So then laboratory. So you have your own dental laboratory.
Correct.
And so Glidewell would be the Southwest Airlines, the Kia, Walmart. Used would be what? The Mercedes-Benz, Beamer, Porsche?
Well, I think we're more of a boutique. I wouldn't say we're really catered to super high-end dentists. We really cater to what I call real dentists. People that are out there that want to do dentistry, want to do good dentistry, want to learn how to do better dentistry. And so, we're not just trying to focus on the prima donnas. My goal really is not to cater to the top 5 or 10% of the dentists. My goal is to cater to the 95%.
Well, what would be your unique selling proposition then when your lab? Is it more that they can get help, or what distinguishes your lab from everyone else's?
Well, first of all, we use what we sell. So everything that we do in our lab, we also do in the practices, and all the technology we sell. So, one of our things is we use what we sell. And so we don't just sell stuff that's, out there that's, being marketed. We use it, we try it in the clinics, we test market it, we feel comfortable with it, we feel comfortable that our technicians can do an adequate job with it, before we're going to turn it out there. But I think, most dentists, and I think you were kind of getting to it with your age groups, most dentists need some hand-holding. They don't want a lab just tell them what to do to sell the latest thing or to pay for their technology. They really need somebody that can give them honest answers about how to do things, or when they're in the middle of something and they forget or don't know how to bail themselves out, or what cement to use, or whatever the problem may be. We're there for them. They call us up and we help them out. And I think that's really one of the big parts of our lab, is really the support that we can give these young dentists, and any dentist really. We really cross the board when it comes to who we teach.
Okay, well, you just walked into a sliding glass door for my next question. She graduated $284,000 in student loans. So she starts wondering, do I really need a $140,000 CEREC machine to be a doctor like Bruce?
Well, first of all, I think CEREC is extremely overpriced. I was one of the first CEREC teachers when I was at UCLA. And we sell CAD/CAM equipment that will do twice as much for about $80,000 less.
Nice. So she goes to your website under distribution. You have CAD/CAM equipment on your distribution center.
Yeah, that's correct.
And so what brand are you selling? That's all that in a bag of chips.
I'd say our focus really has been with Amann Gerbach. Amann Gerbach. It's kind of a German-Austrian conglomerate. One was materials, one was technology, and they kind of combined. Now, I had actually saw it several years ago and was impressed by it. And then when Chad came on board, we kind of ended up in the same place. It's just great equipment, and it does a good job, and it's a lot cheaper. Like I said, it's CEREC.
Yeah, and what, Chad?
I mean, it does full mouth art. It does full arch restorations, bars. It builds titanium implants, everything. And these mills are under 60 grand.
And the other thing, when I went to Sirona in Austria, I mean, there were dentists there that were flying there to buy the CEREC machine there because they were avoiding the $40,000 markup just from Patterson at the time. So when these equipment people sign a what do you call it, a distribution agreement where you can only sell through me, that kind of gets rid of a lot of competition. I mean, that means a guaranteed profit margin, right?
Well, there are other distributors, so we're just one of about three or four distributors in the country. I mean, our biggest claim there is our service.
Your biggest thing is your service, and that you could teach them how to use the thing.
Let me give you an example. if you buy a CEREC, what's really the biggest stumbling block, or one of the biggest stumbling blocks for a practice? You got to have somebody in your office that can run it, and then you get turnover in that person, and then all of a sudden you don't have that person. So having somebody there to do the design work, is important. And do you really want the dentist to do it? Well, the dentist should be in the chair, doing dentistry things, that they're licensed to do. One of the things that we can do is with our equipment, you can actually do the intro scan, send us the scan, and we can design it, and then transfer the information to your machine, and you just mill it out. So you don't have to do any of the design work at all.
Wow.
It's all design. How about that, huh?
That is very cool. You should be making a lot of online C courses on Dental Town to get them over your way. We put up 400 courses, and they've been viewed almost 1 million times. And they're good segues to where they get to see the instructor. And I know anybody that watches you for an hour is going to fall in love with you. I know me and do you remember me and Mike Dotola sitting in your front row several times? I'm surprised you didn't have a limit. What's that?
Didn't he go to Sorona?
Yeah,
Mike?
he was with Glidewell, then he went to Sorona, and I forgot where he's at now, but
musical reps,
yeah, wherever he's at, they're lucky. So before I start asking you a bunch of questions on your education system, what are your top courses and why? Why do you think you've gone from 1,000 square feet to 16,000 square feet? Because right now she's driving to work and she's thinking, my dental school taught me everything. I have no more questions to ask. Of course, she never did a single implant, Invisalign. So what are they calling you up for? What did they not get in school for $400,000 that now they're coming to you for?
Other than the bill, I've been a dentist since 1972. I still take courses, and I'm still learning every day. And I think that's really what the practice of dentistry is. And dental school, in my opinion, gives you the license to practice and hopefully gets you to the point where you're not dangerous. But I think really it's a lifelong journey to learn really how to do dentistry. And you have to learn, and you have to do it. And then you have to learn some more, and you have to do it. And that's why I think it's so important. And if you're going to an education center, learn from dentists that actually do it. The best teachers are the ones that actually do dentistry. And I pride myself on doing a lot of dentistry. In fact, I just tried in a full mouth reconstruction this morning. And so I do it all the time. And I think I make the mistakes, and I try the new materials and techniques, and it makes me a better teacher. But our biggest courses are, I take pride in the fact that we have the longest running aesthetic continuum in the United States. I started at UCLA, and I've done it here for the last 20 years, so probably over 30 years. And that course really provides the foundation for pretty much everything that you need to do restoratively, even some implant stuff in a private practice. And I think historically, the dentists that go through it, think they know a lot, but when they get done with the program, they realize they don't know a lot, and they're motivated to learn more. And I think that's really one of my missions, isn't just to teach, but also to motivate people to keep learning.
Okay, well, this show is called Dentistry Uncensored because I don't want to talk about anything that everybody agrees on. I go right to the hot controversies, and I'm sure you're going to really wish I didn't ask this question, but it's all over the news. A dentist continuing education, it's all over the media where a neuromuscular dentistry has been banned. 2 Canadian provinces ban neuromuscular dentistry. The Ontario Manitoba College for details. The question to this is, when she comes out of school, she wants to learn more occlusion. And my question is, why is occlusion so complicated? I mean, you'd think complication would be molar endo, getting out a broken file. Why is occlusion so complicated? And when she's going through her journey, she says eloquently in her emails to me at howard@dentaltown.com, well, it seems like I need to either pick between neuromuscular or CR, Pankey, Dawson. And now the questions are all like, well, didn't neuromuscular just get banned in Canada? And yeah, it's on the news. It was KTVN, dentist continuing education linked to overtreatment of unsuspecting patients. Dentist author of the banned book, Confessions of a Former Cosmetic Dentist. say dental patients often had whole mouths over drilled by dentists taught neuromuscular dentistry. So just, I threw like 40 things at you. So hopefully one of them was intelligent enough for you to answer.
I think it's a very simple answer. If you think occlusion is all that complicated, you don't understand occlusion. I think it's quite simple. You know, the whole genesis of my prosthodontics education was occlusion. This was before aesthetics and, you know, before that stuff. And I learned how to do panographs and tripoding occlusion and all that stuff. What I really learned over the years is you can make 95, maybe even more than 95% of your patients happy by not making it complicated. You know, it's as simple as giving people a good stable centric occlusion and anterior guides. It's really just that simple. Now, you do have people with deteriorating joints and, you know, psychological problems. And I mean, that's, you know, that 5% maybe. But I think that people that try to create a camp, they want people to come to their camp to learn about, you know, whatever, you know, and I think even neuromuscular dentistry, if you look at the technology, it's pretty clever. You know, you get TENS units that relax muscles. You can, you know, they're electronic devices. It's kind of like an electronic pantograph in a sense. You can see motions and timing, you know, but is it really necessary to use that for every case? I don't think so. I have the technology, and I find I rarely use it because it's not necessary. And I think neuromuscular got its bad name because I think it went to LVI. LVI promoted it as a way to get a bunch of full mouth reconstructions, and it led to that possibility of maybe over treatment, and that's kind of where it's got its bad name. But you got to ask yourself one thing, Howard. You got neuromuscular dentistry, you got CO dentistry, basically, you got CR dentistry, a long centric, all these different philosophies. They're all still pretty much here. You know, if there was something really all that terrible about these philosophies, don't you think they probably would have gone away? And so I look at it a little bit differently. I look at it, if these are still around and there are disciples of these techniques, you know, what is it that they know, and what part of that technique can I add to my armamentarium to make me a better dentist? Because they all have something, I think, that can contribute to making you a better dentist. But again, occlusion isn't that complicated. We have an advanced fixed prosthodontic program where we teach people how to do full mouth reconstructions. But I call it the baby steps. I don't teach how to grind full arches and take full arch impressions. I don't want to do that. It's too darn hard. I'm old. My butt doesn't have any fibrous tissue left. I can't sit that long. You know, so we teach people, I call it the baby steps. We teach them how to break it up into segments. And I can teach a third-year dental student how to do a full mouth reconstruction. Okay, but you got to know how to do the baby steps. The only difference between a specialist, a prosthodontist, and a general dentist, I know how to organize. I know how to organize things that make sense, and I understand the process from beginning to end. I know the journey. Okay, and I think that once you learn that, you learn how to work your occlusal philosophy into that. With a few exceptions, it's not that complicated.
Okay, here's another thing. True or false? She's driving to work right now, and she's thinking, oh, yeah, Howard and Bruce, two old guys who graduated in the golden years of dentistry when it was all high fee, low volume. And now she's walking out of school, and it's all low fee, high volume. And she's saying, Bruce, it's 2019. Can I still have a high fee, low volume practice, or do I need to start learning how to do quadrant MOD composites in an hour all day long?
Yeah, I think with bills that students have or graduates have in dental school, it makes it really tough. I mean, I think that's a huge obstacle, and I think that really has changed dentistry, and that's why you're seeing a lot of what do you call corporate dentistry, where they go in and get a salary, and same with medicine, obviously. But I think that, you know, if you're going to be doing something for the rest of your life, you know, you got to kind of create the vision of what you want. Okay, you create a vision for what you want that makes you happy. You know, don't get defeated by the fact that maybe you have to do something you don't want for a while. But if you don't have a vision of where you want, if you don't have a destination, you're never going to get there. Now, let me give you a good example. I had a really a good student of mine. His name is Todd Snyder. He lectures a lot. Maybe you heard his name. But he got out of school and he took all my programs and he assisted me in an aesthetic, a 2-year aesthetic program I did at UCLA. And he made the decision that I'm just not going to go out and fall into that trap. I'm going to have a vision of what I want. I want a fee for service practice. Now, granted, you still have to take some insurance and maybe you got to associate part-time or whatever, but you still got to have a vision. And he struggled for a few years. He struggled for several years. But, after he got through that, and because he had the correct vision, he eventually got to where he wanted to get. And so what's 5 or 6 years, even if it takes that long, or 7 years, out of the rest of your life? Or do you want to just be mired down in the kind of practice you don't want for 30 or 40 years? And I think the decision to me is pretty simple. Sometimes it's maybe just take the easy way out. It's fun making money when you get out of dental school and you get into these practices and you're all of a sudden making money. But I see the same cycle over and over again. You make money 5 or 6 years, you're drilling and filling and seeing 20, 30 patients a day. Dentistry isn't fun anymore. And to do that the rest of your life is pretty tough. And my focus is to try to teach dentists how to kind of break that cycle.
Tom Snyder was on episode 408, and it was a great show. Back to these back to doing more complex cases, and I'm asking you questions again. These are what I'm hearing from 30 and under. Okay, she's like, okay, so I got out of school and I went back to my hometown, and I thought my dentist was amazing. I'm working for him. He doesn't even own an articulator, and he says I don't need one. How do you answer that? And this dentist, by the way, might be her mom. So tread carefully on this. You're on black ice.
Yeah, they probably own an articulator, but they use it for their boat anchor or something, because
So what do you do when you graduate from school? You go into practice with your mom, and she doesn't own an articulator, and she says, "Trust me, you don't need one."
Well, I look at the good and the bad news. First of all, dental school hasn't really taught that individual, why you want to use an articulator. I mean, they've got programs. They take a Facebook. They don't really understand why. They don't teach them simple techniques, to program an articulator. They don't, and they probably never do more complicated cases, maybe a denture or something, But I think by today's standards, if you're going to do cases 6 or more, and probably even sometimes less than that, you really need an articulator. And the beauty is you only need one articulator. You don't need a bunch of articulators anymore. You need one articulator. The lab needs that same articulator. You have magnetic mounts, and you just keep sending your magnetically mounted models back and forth. And so it isn't really that expensive to get a good articulator. We have.
Well, what's the name brand? What's the name brand of the articulator you just said? Magnetic mounts, all that kind of stuff.
Well, there's a number of them. The two that we focus mostly on in our academic programs are the Panadent and the
Artex.
And the Artex. Artex is sold by Gerbach. That's the company that does our CAD/CAM equipment. It's a carbon fiber thing. It's really clever. And then Panadent's our local company here in California, and they make great stuff too. In my lab, I've got about 200 articulators. So that's the sign of a good prosthodontist, right? I have lots of articulators. But I don't need that many, believe me. But I use primarily Panadent and Artex, and we sell those too. Good prices.
All right. I want to go back. Like I say, I want to stay true to my homies, and I'm going to go right back because I knew who they are. They send me 300 emails a day, and so again, they're working on 4 6-year molars. So when so it's kind of like when she wants to learn an implant. I guarantee you, go to the CDA meeting or the ADA meeting, they'll have a whole bunch of lectures on all on 4. And she's like, dude, I'm in Oklahoma doing an all on none. And, everybody wants to talk about full mouth rehab, and she's trying to do a crown on a 6-year molar, or her first veneer case or whatever. So I'm going to go through, like I say, I'm here to abuse you on behalf of her. A crown on a 6-year molar. What do you think are things that she needs to think about?
Well, first of all, does it need a crown? I think crowns are really overdone. If the tooth is really that bad a shape, it may need a crown, but oftentimes it just needs to remove the restoration and do an onlay. My saying in preparation is you just keep going until you get to something good tooth structure, color, whatever, and you stop. And then you make an adhesive restoration. That's the beauty of contemporary restorative adhesive dentistry. You don't have to be invasive. And what's the beauty of that? Less tooth invasion, but it's easier. If you don't have to go below the tissues, you don't have to worry about bleeding, you don't have to worry about periodontal problems, you don't have to worry about impressions. It's just easier. And I like to say, why make it difficult when it can be easy?
Okay, so
too many
she
people
she took out the
around.
MOD amalgam, she took out all the decay, and she's got what's left. Walk her through. What would you do next?
Remove the decay, look at the integrity of the cusp. You do occlusal reduction if it's necessary. You may not even have to reduce both cusps. A lot of times you can leave the non-functional cusp if the functional cusp is a little, thin. But even still, if you knock down both cusps, you got occlusal clearance, and you have a fair amount of thickness of your cusp. Basically just connect the boxes with the cusp, maybe a little peripheral chamfer, and you're in business.
So would you take an impression? Would you oral scan? Would you temporize? Would you chairside mill? What would you recommend?
Well, I think it's also, if you're going to make any money, you got to be efficient. So I always I snap my impression first. So I can be trimming that while the impression's in the mouth. If you don't have an intraoral scanner, I have intraoral scanners, so I'm going to do both. Sometimes I'll take a traditional impression, but a lot of times I'll take an intraoral scan. And then I just send it to the lab, and they don't even have to make a model.
So the scanner, some labs are saying that when their clients send in a scan, they have 1% remakes. When they send in a vinyl polysiloxane or vinyl or polyether, it's a 5% remake. Do you believe that, or do you not believe that?
I think if the dentist that's doing the scanning has good tissue retraction, so you can see the margins, I believe it. It's blown me away how accurate they are compared to the old CEREC and some of the old digital technology. It's unbelievable.
And she always, one of our biggest complaints on the show is that they won't name a brand. Like you said, oral scanner. And she's like, come on, dude. Are you talking about 3Shape out of Denmark? Are you talking about 3M's True Def? Are you talking about Line Technology owns iTero? She might be getting into Invisalign. So which oral scanner would you anchor to?
Keep in mind that I'm a dentist, so I look for products that make sense for me as a dentist. So initially we got involved with Kodak for our intraoral scanners. Then we went to CareStream, took them over. And so CareStream, we got our CT machines from them. And now we use the CareStream intraoral scanner. I will say that we sell that. But I didn't start selling it before I bought it. I got it before I started selling it. Does that make sense? It's a fantastic technology. And if you look at some of the research, it's as good or better than just about anything out there. And it's certainly very competitive. In fact, they're coming out with a brand new one that's even better. We just saw it this week, early in the week, the rep came by. So that's the one that I would recommend. There are really good scanners out there, but I think CareStream makes some fantastic, CT equipment and scanners. They're also getting into the CAD/CAM, the chairside CAD/CAM market, and so so you can integrate everything, and so I would certainly start there.
So you're talking about the CS, the CareStream 3600 for dental restoration intraoral scanner. That's the one you're liking. I'm sorry, Chad. Did I interrupt you? What did you say, buddy?
It's all right. They're dynamite comment right now. It's a CS 3600 to the CS 3100 mil. It's powered by exocad chairside software. And the beauty of it is you can go from an intraoral scan to actually finished product at the mill in under 20 minutes. A completed finished restoration.
Wait, say that again. You can go from what to what?
Intraoral scan, design the crown, then mill the crown in under 20 minutes. So you're looking at 17 to 23, 24 minutes, depending on the size of the restoration and the material you're using. But, we have videos online on our YouTube channel, Sarah Professionals, a YouTube channel also demonstrating all of this. One of our sales girls, Holly, is walking you through the entire process on the chairside software by exocad. And it's just amazing.
Wow, that is amazing, because that's the biggest beef against chairside milling is that the patient was in the operatory for 2 or 3 hours.
Yeah.
And what do you think? Again, back to that 6-year molar. She comes in, she's got a numb, she preps a 6-year molar, scans, mills. How long do you think that appointment could be reasonably?
I think what you have to do, you have to learn how to appoint. Okay, obviously you have anesthesia, well, usually anyway, and you gotta prep it and make your impression. But to be sitting there waiting while this thing is milling, you're up working on somebody else, and so your staff is designing it. If you got your own intraoral scanner, your own intraoral mill, you may design it. You could design it off-site. That's possible. And so that's milling and finishing. And then, it depends on where it's at in the mouth. If it's in the aesthetic zone, you still may have to do some ceramic staining that takes some time. If it's in a non-aesthetic zone, you could basically mill it, polish, and cement it. So that's where, the 6-year molar oftentimes is a pretty speedy process. And Carestream is, not Carestream, but Amagurbag has developed a different milling strategy for crowns and onlays just to make it faster. And so it is pretty time efficient, but I think you still have to know how to schedule so you're not sitting there waiting. Your patient may be sitting there waiting a little bit, but you're not sitting there waiting as a dentist, using up your valuable chair time.
And you were talking about impressions versus intraoral scans. And you remember when you're doing an intraoral scan, the software that Carestream utilizes, their CS imaging software, what's the lab's biggest complaint? Look, I've got no room, I can't see the margin, et cetera, when you get a traditional impression. Well, the dentist goes and they do the preparation, they do the scan. Well, you've got that prep, right? This big, we're sitting right in front of you, right? You can see undercuts, you can see, and with the software, it'll show you instantly if it's got an undercut. What is my clearance of the opposing tooth? Do I have enough room with this prep? It walks you through all of that even before you even send it to your mill or send it to your laboratory if you don't have a mill. So you're not losing another appointment by getting them back in because you don't have room or the prep's wrong or something's going on, the impression's bad. And that really chair time and saving chair time, that's where you're going to actually make most of your money.
I did one yesterday and I took the scan and I can do a pretty good prep, but I just didn't I had a little bit of a rough spot on my facial margin. So I just went back, prepped it, did another quick scan, took me about a minute. It allowed me to evaluate, make sure it was the way I wanted it, retake an impression all under probably a minute or two.
Okay, one of the questions millennials always ask is it an open or closed system? So in regards to this Carestream Dental, if she buys that, does it work? Is it an open format with other technologies, or is it you're in Carestream and you're in a closed system?
Yeah, I wouldn't buy anything that's a closed system, period.
Okay, explain. Some of them might not even know what we just said. So explain what I just said and what your answer was and why, in case you didn't understand open or closed.
For my generation, I like to kind of equate it to stereo systems. You could buy a stereo system that's all one company, Yamaha or something. Or you can go out and pick your speakers from one company, you pick your turntable from another company, you pick your receiver or whatever from another company. Well, it's the same way with this technology. You can get your mill from one company, you can get your scanner from another company. So you can kind of pick, I guess whatever you feel is best for you, or maybe it's the price, maybe it's whatever your criteria are, and then you can put them together any way you want. That's an open system.
I think one thing to remember when you're looking at intraoral scanners is, you've got 3Shape, iTero, Carestream, et cetera. One of the big things they say, okay, well, you can export a STL, native STL, which will be incorporated in any other technology. But you know what? We're going to charge you to do that. And on top of that, it has to go up to my cloud and then get spit down back to your network. And the problem is that just increases chair time. Carestream came out early and fast as a completely 100% open software. And the beauty of it, it goes right from the scan directly into your network, directly onto your hard drive, directly onto your laptop, whatever you're scanning to. That's a truly open scanner, right? There's no fees, they don't charge anything, and that's the beauty of it. When you get into all these others, they say, yeah, it's open, but they're going to charge you a monthly fee for that. And that's just not open.
That's why I got my first Carestream scanner. Not all the hidden costs.
Well, the biggest, in the minds of the closed system, it would have been the Cerax Sirona, right?
Right.
Which
I think they've slowly started opening up too.
Yeah, but what it reminds me of is when I was little, I got out of school in '87, and Siemens was the biggest company in Europe, and their CEO decided they were overweighted in healthcare and need to have more consumables, so they spun off Sirona, and the building was the same; it didn't move. And then Sirona eventually had to get married to someone. Then they bought X-Ray. They merged with X-Ray. So now it's Dentsply Sirona. And now it is 30 years later, and I'm seeing the same thing with Danaher. Danaher is spinning off their dental division. It's gonna called Invista Holdings, NVST. And I was wondering, when a company like that spins off, when Danaher spins off its whole dental, do you think it'll get married with, do you think Lisa Ashby, the CEO of Carestream, do you think she'll get married to that company, or where do you think those Danaher assets will end up at?
I will tell you, I had a lot of great relationships, a lot of companies. I've been to Beaverbrook, or not Beaverbrook,
Beaverbrook,
yeah. I've been to that plant where they made CEREC, because when I was at UCLA, we were kind of the leading edge of a lot of their technology. And
you were the UCLA Center.
I started UCLA Center for Aesthetic Dentistry in the 80s. It was the first one in the United States in a school, in a university. But anyway, yeah, I've been to Cabo in Germany, and a lot of these companies occur. Every company, in my opinion, that, and I guess I maybe shouldn't tape this, but I will anyway. In my opinion, every company that Danaher has purchased has become totally a bottom line company, and they're almost impossible to deal with. All they worry about is the bottom line. They really don't care about education. And as far as I'm concerned, all those relationships with the company that Danaher had, I bought, $300,000 or $400,000 worth of Cabo dental equipment. They decided not to make it anymore in America, and I can't get parts, so I had to replace it all after 10 years, and it should have lasted 30 years. And so Danaher, in my opinion, has really screwed up a lot of good companies. And so I don't know, maybe if they sell dental, maybe it'll be resurrected by somebody, I don't know, but currently they're kind of on my my naughty list.
And that's really surprising, because Danaher's in Washington, D.C., and Washington, D.C. never screws up anything. I mean, usually they're always fixing everything in that town of geniuses.
Now I know. That's right.
Yeah, be interesting. But yeah, are you, next time you talk to Lisa Ashby, tell her I'd love to get her on the show. I got the same Carestream too. But I think I'd like to, I think dentists like to hear from the people they're buying from. So I'm still going to hold your feet to that fire. She took out the MOD amalgam. She took off everything until it's good sound tooth structure left. You talk about oral scanning versus impression. Everybody wants it tooth colored. What material would you go with? And would you cement it? Would you glue it? Would you mill it chairside? Would you send it to a lab?
Well, it depends on what technology you have. So if you've got a mill, you're going to use your mill. If you don't have a mill, you're going to send it to the lab. And I think the materials available right now, I would lean towards the crystalline ceramics with zirconia, like the new, what's it, Vita? Suprinity is a very clever material that just got clearance. It's a little stronger. I think Emax has been kind of the traditional buzzword when it comes to onlays and single units. But and it's a good material, don't get me wrong. I use it a lot. But I think for, those single units, I opt for something stronger, especially in a lesser aesthetic zone, like a first molar. The newer translucent zirconias are stronger than Emax, and I've done comparisons in my lecture where, they're pretty much the same translucency as an Emax onlay would be, and they're, substantially stronger. Okay, and we pretty much got through the cementation process, so I don't think that's an issue anymore.
I'm a cosmetic dentist, which means whenever I enter the room, I just dim the lights and I instantly am more beautiful. Yeah. But still, would you cement it or would you bond it?
If I do full coverage zirconia, it has the strength. We got traditional circumference retention like a crown. I use a resin modified glass ionomer, like the fluoride, and you do get some bond. Because you don't really need it. You don't need the adhesion to retain the restoration. But when you start doing onlays or crowns, maybe with lesser retention, then you got to use adhesive technology.
Okay, but you did name brand. So when you cemented a full zirconium crown, what would it be?
Full zirconium crown, I would use a resin modified glass ionomer. I use Fujisim too from GC. There's a lot of good ones out there, but that's the one I've used for many, many years. Fuji makes some great, or GC makes some great cements. If I'm doing Emax, then you pretty much have to do adhesion. So something strong like zirconia, you can cement a crown. And pretty much everything else, other than maybe gold, not too many people are doing those anymore, but pretty much everything else, if you're looking at Emax, you got to bond it. If you're looking at something in the same kind of strength range as Emax, you're going to bond it.
And
translucent.
what would you bond it with?
You're going to use dual cure resin cement generally. We recommend doing a selective etch. So you etch the enamel, self-etching, bonding systems, and then a dual cure resin cement.
But what's your go-to system for bonding?
Actually, we have a few. I like Cosmetic stuff. We use a lot of Danville. Danville's a little company that just got bought by Zest. Bertolotti was involved with them, and he's a pretty sharp guy. And so I got involved with their materials. They're really good. I like their bonding system because it has, pretty much everything. It has self-etch, total etch, and dual cure all in one bonding system. It's called Prelude. We use that a lot, especially in our classes. We have so many products here because we're a school. It's hard to say, but the cements, like I said, I like Dual Link from Cosmetic Dentistry, great cement. We use, another company that, I think is a little lesser known on the West Coast. I call it the Ultradent of the East is PulpDent. PulpDent makes some really clever materials.
In Boston.
So they got their, their bioactive liners and restorative materials. And they make some good cements, bioactive cements. They make some very clever materials I like. There's a lot of them. But quite frankly, I don't think there's a huge amount of difference between resin, the dual cure resin cements. They're all similar. So,
Bruce, walk me through this logic. I mean, it seems like when I got out of school in '87, it was all amalgams, PFMs, and gold. I have 7 onlays. They're all gold sent with zinc zinc phosphate cement. And it looks like the amalgams, it was all active ingredient. I mean, it's half mercury. You'll never find that in a multivitamin. The other half was silver, zinc, copper. Look at silver diamine fluoride. Look at tin, stannous fluoride. I mean, it was all active ingredients, and they lasted forever. And our best idea was to make them cosmetic and take out all the active ingredients. And it looks like the silver filling that was lasting 3 decades is now replaced with an inert plastic tooth-colored. It's pretty. It's so pretty, but it probably doesn't last a decade. True or false?
I think that's false. And I've seen composites last many, many years, and they keep getting better, especially indirect ones. But if you're looking at direct restorative materials, obviously you have some technique sensitivity. But if there was a dental school that the students were taught how to do composites, in which we thought were really hard when we were just doing amalgams. And then they were taught amalgams after the composites, and they thought the amalgams were hard. So, it depends on what you're taught. But to answer your question, I think if you look at an amalgam, what are you looking at? You're looking at a white tooth, you're looking at a dark gray restoration, and are those margins breaking down? Yeah, but can you really see the breakdown necessarily? When you look at a composite, you got white and white, and if you got a little leakage or deterioration of the margin, you can see it. But I think I quit doing amalgams probably 30 years ago, not because I didn't think amalgams were necessarily a bad material. I mean, small amalgams are great. They last forever. I just didn't like the fact that I was getting no ability to strengthen the tooth. And I think if you're using something that you can bond to the tooth, my goal is to try to slow down the deterioration process. And if you look at you've been around long enough, you realize when amalgams were there, they became amalgams, then they became bigger amalgams, then they became maybe gold onlays or crowns, or maybe PFMs, and that was just the cycle. And I think that as dentists now, we can break that cycle, and we can certainly slow it down, with our adhesive products, with our adhesive technology and materials. And I've been teaching that for 30 years. And that's what, as a prosthodontist, it was kind of heresy to do bonded, restorations back, 30, 35 years ago. But that's what enticed me. It was doable by, any dentist. And it's a win-win situation. It's really easier, and it's better for the patient.
Okay, a follow-up question. The amalgams had active ingredients. I mean, whenever you're leaching mercury, silver, zinc, copper, tin, life is not going to be too pleased with you. But you mentioned these glass ionomers and PulpDent, where now we have composites that have ingredients. Some people say, yeah, those are active ingredients. Those will help prevent biological infection, caries coming back. Other people say, no, it's all marketing. Do you think these composites with glass ionomer, PulpDent stuff, do you think these active ingredients are actually going to help prevent the bacterial infection of Streptococcus mutans?
I call them contingency plans. if I've got a fairly deep preparation, let's say I have a deep axial wall, am I just going to put an onlay on that, especially, in that cervical area? And where's it probably going to leak? It's probably going to leak in that cervical margin. Okay, so in that onlay, I want it to last 10, 15 years, maybe longer. Okay, so what's the probability that I'm going to get a little leakage in that cervical margin where maybe there's no enamel? So my philosophy is I want a backup plan. And so what I'm going to do, and I don't put it on every restoration, but if I've got deeper areas that are closer to the pulp, I'm going to lay a little fluoride-releasing bioactive material over that deep area. So if and when I do get a little micro leakage down the road, it's going to run into a little bit of a roadblock, hopefully to slow it down. And that's kind of the philosophy I operate on. I don't like to just teach always do this or always do that. There's got to be a reason to do stuff. And if you're using more materials or doing additional techniques, you ought to have a justifiable reason for doing it other than I always do that. That's not the right answer.
I'm going to ask you a question, and you're probably going to roll your eyes and think, where did this come from? But these are actually emails question. Okay. She just did that one crown on one tooth. Now the patient thinks that it's causing TMJ. How would you even get your head around that?
Well, first of all, you got to do a good evaluation before you start patients, to make sure they don't have any pre-existing conditions. That's the first thing. That'll keep you out of trouble most of the time. If somebody develops symptoms, why are they developing symptoms? That's a good question. I mean, the normal dentist usually would just go in there to develop a system, and what do? They grind it out of occlusion. But I never grind a tooth out of occlusion unless it needs to be ground out of occlusion. You got to see, is it really high in occlusion? If they are developing symptoms, the other problem is a lot of dentists they only adjust centric occlusion, and they don't necessarily adjust lateral excursions. And a lot of people don't have very good canine rise. And if you put a crown in, maybe it's good in centric occlusion, but they don't have very good anterior guidance. And all of a sudden they're going into working or balancing interference. This is, again, occlusion 101, and they start picking up working and balancing interferences. It's going to change the chewing patterns of that patient. And you could kick somebody over into having symptoms, because you never really know where they're at, if they're on that border between being symptomatic and not being symptomatic, if they don't have any symptoms, before you do the crown. We also do a course in occlusion, this kind of intro to occlusion, staying out of trouble. We have a really clever dentist coming up from Carlsbad. His name's Brad Eli. And his whole approach, he treats a lot of symptomatic patients. He makes a thing called the splint, what's it called? Anyway, it's like an immediate splint kind of thing you make. But his whole approach to teaching symptoms is how to avoid symptoms when you're doing dentistry, which is a little different approach. Don't wait until you have symptoms, after you do the dentistry, try to keep the patient from having symptoms, by following some certain principles. And I think that, we've developed some things like the helping hand, which is a device that you can actually put over the front teeth where the patient actually can hold their mouth open and control it, rather than putting a wedge in their mouth, a wedge you can open and subluxating the joints. Those are the types of things that can cause post-operative sensitivity, TMJ symptoms possibly. So you want to try to avoid that. So these are some of the things that we teach.
By the way, if you want to study the canine rise, who has the best canine rise ever? Warthogs, pigs, and walruses. I mean, if they're not sporting the biggest canines on earth. And by the way, the elephant's tusk is not a canine, that is incisor. I want to change subjects completely with you. When you go around the world, and Dentaltown has 250,000 members from all 200 countries, 69,000 are on the app. So they're from everywhere. But what you're hearing from Japan, France, London, Australia is that insurance companies have pretty much made the routine practice of cleaning, exams, x-rays, and fillings. Basically, you just barely break even. And everybody that is gravitating towards the two procedures where the insurance doesn't set the fee. And that's clear aligners and implants. Like when we were doing this podcast from Tokyo and France and London. The Japanese dentists were telling me the Japanese dental insurance pays me $100 for a molar endo, and I'm in Tokyo where the ground is $1 million US a square meter. We have to pull the tooth and do an implant. I mean, we're not from Mars. So if she wanted to get into clear aligners or implants, let's just take implants. What advice would you give her? She says, I want to get into this implant thing. I want to place my first implant. I went to UCLA. I graduated $14 million in debt. I didn't get to place an implant. What advice would you give her to take the first step of her implant journey?
You know, we did a lot of implant programs where they did, things on models. That'll teach you the nuts and bolts to a certain degree. And we did courses where they might place one implant. And the average general dentist never really followed it up because they still didn't have that comfort zone. Now we do a program with Dr. Frawley, who was on your broadcast a while back. We do a 4-day program where they actually do, 8, 10 implants, they extract teeth, they do some bone grafting, so they really get a lot more experience doing it. So obviously I'm biased. I have an education center. And so, education is really the key to, I call it creating the comfort zone. If you don't have the comfort zone, you're not going to do it. So you have to go someplace where you can get that comfort zone. Some people can watch a video and get a comfort zone. Some people need to go to 4, 6, or 10-day program, and, still may not have the comfort zone. So there's everything in between. But I think education is a key. And a focus here for our programs is, hands-on and clinical. We're one of the few places where you can actually go and get clinical experience in most areas of dentistry.
And some mentorship.
Yeah, in our mentorship programs. And then we're available to help you after the courses. We're always available to hold your hand and help you out. So that's one area. I think another area that I don't think it takes the place of good technique, but certainly guided surgery has been helpful. Okay, we do some courses, Hoyas, and we actually make their guides. And I think that for someone that's afraid of getting into a nerve or a sinus or something, when you've got a guide that keeps you out of those areas, it does give you a little more confidence. Now, it doesn't take the place of good surgical techniques. You still have to have, reasonably good surgical techniques, but I think that's extremely helpful as well.
Or
education experience. How did you learn how to do dentistry? You didn't go to dental school and all of a sudden you felt comfortable doing everything. You do something and you learn something. You do something and you learn something. You learn something a little more advanced and you do something a little more advanced. I mean, that's the process. You make a few mistakes along the way and you learn not to do that anymore. I mean, I've done this a long time and I've made a lot of mistakes, and I think that's why I'm a pretty good teacher, because I've made a lot of mistakes, but I've done a lot of things right too.
I went to dental school so long ago. When I went to dental school, the Dead Sea was only sick. That's how long ago it was. But I think if you want to learn dental implants, just don't do anything, because I hear that robots are going to be replacing implants. I heard an implant was placed in China by a robot. Shouldn't you just sit back and wait for Patterson to sell the robot that places the implant?
Let's go back to your comment about insurance. Because I think, why do you think cosmetic dentistry got so popular 20-some years ago? Because it wasn't really covered by insurance. And so it was covered by people that had a need or a want, and so people want their teeth straightened. So there's these aligners, kind of puts ortho in the hands of people. Veneers generally isn't, if it's just for aesthetic reasons, isn't covered by insurance. And so that allows dentists to develop fee-for-service components of their practice and get out of that, drill, fill, and send it off to insurance and not get paid. And we have another practice in our facility here where we do accept some insurance companies, and our hygienist was charging more than we got paid for the cleaning. So we said, well, this is stupid. So we just said, forget that insurance. So we're going back to more of a less insurance companies and more of a fee-for-service. But the point is, going back to what I was saying, you have to learn how to do things that you can add to your armamentarium that's going to make you better or different or special in your dental community, and things that aren't necessarily just covered by insurance. Because a lot of people will buy good dentistry if they have a need, and you got to be the one that's there to supply that need. To me, it's just that simple. Is it an easy transition. I mean, you're going to walk in and it's going to happen immediately. It's not going to happen immediately. It's a process. It takes time, but you got to start somewhere.
Okay, I'm telling you her fear. You know, you're either happy and pursuing happiness, or you're fearful, have anxiety. So she gets out of school. She goes back to practice with her dad. Her dad's telling her to learn implants, and she's looking at all these implants that her old man's done in the last 5, 10, 20 years, and she thinks a quarter of them, a third of them have gum disease around them. So then she's saying, you know, the person that gets a dental implant, that usually wasn't your yoga instructor addicted to TAFU. That was usually your smoking, drinking Irish buddy. And so patient selection, I mean, she's confused. So what about all these implants, all this PeriImplantitis? And what do you do when you go into the room and he's sitting there with his bottle of Jameson and he says, man, my tooth's fine. I don't feel any pain. I can eat a Big Mac. And she's like, my God, the hamburger around there, it's all inflamed. It's all PeriImplantitis. So how do you address the growing revolution of implantology with the growing morbidity of PeriImplantitis?
Well, I think first you got to realize that, you know, the whole arena of implant technology and diagnosis and grafting, you know, has really advanced in the last 20, 30 years. And so I think that if you can get a good foundation by today's standards, you are going to have a pretty high level of success. Now, having said that, I've been doing implants and restoring implants for many, many years. I bought UCLA their first implant system when I was head of the clinics there. And I see these patients coming in with lots of threads showing and lots of recession. But, you know, interestingly, if you can keep the disease moderately under control, you know, they can last a long time. You know, you can go in and smooth the threads, or, you know, get them on water picks or whatever, you know, and just because you've got some, you know, some bone loss and stuff, and it's probably going to happen in some of your patients over many, many years, you know, it is fairly controllable, I think, you know. And is it to the point where, you know, they're so infected they got to be removed? I don't see it that much. I mean, some do, yes, but, you know, I think the other thing you got to look at is implants, the answer to all the solutions, to all the problems. You know, my practice started way before we were doing predictable implants, and I don't have problems doing bridges. I do a lot of bridges. You know, if somebody has a missing tooth, I don't automatically assume it's got to have a bridge. Now, if the teeth are pristine and they got a dentulous area, I want to do an implant. But if they got crowns adjacent to an edentulous area, I mean, I think a bridge might be a better solution for some of these people. So, you know, I don't like to be dogmatic. I'm not a very dogmatic person. So, you know, I think there's still, you know, a lot of solutions other than implants that'll get the problem done.
Yeah, and I think if you're dogmatic, you're not a doctor. I mean, you know, no. I mean, you're just not. If you have a one size fits all, I mean, like I know dentists will have a patient come in, they'll have 8 root surface cavities. He's Alzheimer's. He doesn't even know the name of his own child that's taking him to the appointment. And they're trying to do these high aesthetic bonding things when, my God, glass ionomer, amalgam, anything would be better than just some, you know, aesthetic composite. And he's like, well, I'm a cosmetic dentist. It's like, yeah, well, that guy in front of you doesn't even know he's alive. So shouldn't you make something that would last 2 years instead of something that lasts 6 months? I want to switch gears again completely. Went from crowns to implants. I want to go back to your dental laboratory. You see a lot of incoming cases all day long. What do you think? You know, they're just seeing the case they're sending in. They don't get to see all the incoming. Well, what is the low-hanging fruit of all the incoming, where if they were seeing all the incoming, they would not be sending you this? What are you seeing that you think, what are you seeing at 1,000 feet, at 30,000 feet looking down, that she's not sending up an impression?
Well, I'm a little bit fortunate in that most of our lab clients are my former students. And so, you know, they've come here and they've learned better techniques, and they know that I got to take a look at things and I help them. But I think that, I think in the lab business, the things that probably create the most problems is going in there and doing something irreversible before you really thought out what you're doing. You know, they'll go in and prep something without thinking about the rest of their mouth. they prep maybe some anterior teeth or posterior teeth, but the case really needs a vertical dimension change, and they're wanting to do 4 crowns, but it really needs ultimately a change in vertical dimension. So, they haven't really thought through the total treatment. So anytime you start a treatment when things get a little more complex, because the 1Z, 2Zs, 3Zs in our lab are not a problem. We get good impressions for the most part. We send them back if they're not, but pretty much we're getting pretty good work. But when they start doing more complex cases, that's where you really got to know what destination you're heading for, and you got to sequence it. We teach people how to do full mouth reconstructions. If you can do 6 teeth at a time, you can do a full mouth reconstruction. Any full mouth reconstruction, with very few exceptions. And so it's just a matter of knowing your destination and learning the baby steps and how to sequence it.
Providing information.
Yeah, so we provide that kind of information.
And you can't make this up. His lab is in Tarzana, California, right?
Tarzana, California.
Which was named after Tarzan, right?
The author of Tarzan had in the state here.
Yeah. So if Tarzan came into your office and needed a crown on number 6, since he's so muscular, just like me, would he have to have a full gold crown? Could you do an Empress? What's the single unit crown you would do on Tarzan?
Yeah, I don't use gold. It's too expensive. I use a zirconia crown.
You use zirconia?
Yeah.
And you would cement it.
Yeah. Well, if it's an onlay, I would use adhesive technology. If it's a full crown, I would probably use a resin modified glass honor.
My gosh, I can't believe we've already gone past an hour. One last question, if you got time for some little overtime, is you always talk on your website mentorship. You got a section just on mentorship. What does mentorship mean to you, and why is it one of the sections on your website, which is aestheticprofessionals.com? Aesthetic. By the way, why is aesthetic? So aesthetic, ESTHETIC. That's what, English, and then if it's AESTE, aesthetic, it's French. Is that right? Aesthetic and aesthetic, English to French.
The AE is more of a European. The E is more of an American, at least to my knowledge. So.
Well, you know what my research found on it was that when they started printing, all the printing was by the cost. Like a lot of British words have an extra letter in them, but due to printing, the Americans thinking everything faster, easier, lower cost, they would take out letters just to reduce the cost. Kind of like when we got out of school. Remember a classified ad had only like dental assistant wanted, and it was like $300. You couldn't. You couldn't afford to say anything else like 5 years experience, just like Tarzan, me want assistant. There, 300. So they took a lot of those letters out just for the cost of typesetting. But what does mentorship mean to you, and why is that a section on your website, aestheticprofessionals.com?
Yeah, we used to call them, residency programs, and education is a tough sell. Everybody thinks they're going to get everything they need to learn online, and they don't need to go to a program. That's why we focus on hands-on and clinical. But the feedback I was getting is that younger people, which I guess is the people that watch this program, wanted people to mentor them. They wanted somebody they could contact and get information from, and not just a one-shot deal. It would be an ongoing thing. And so we changed it from residency to mentorship. We modified them. But we pride ourselves, we call mentorship for life. Once you take one of our mentorship programs, you're one of our alumni, we will mentor you forever. And so it's not just you come, you go, and that's it. So mentorship to us means, once you become a part of our alumni, group of alumni, that we're there for you to help you out in any way we can. We are your mentors.
Well, Chad, we went over an hour. We're at an hour, 4 minutes. I want you to wrap this up with, what do you think she doesn't know about? She already gets all of her supplies and equipment through her local dealer. Say she's already using Benco. What is she? How are your supplies and equipment different? And what should she know on your website about aestheticprofessionals.com as opposed to Patterson, Shine, Benco, Burkhart?
I mean, easily the difference, the products are the same. I mean, that's pretty simple. But what sets us apart is that we actually have opened that container and used that clinically or in our laboratory. We've touched the material, we've touched the equipment, we've touched the software. And when another representative from another company, Benko, Patterson, whoever it is, walks into their, they're reading cut sheets, they're reading sales reports, they're reading, very few technicians are salesmen for Benko or Patterson. They're great guys. I know a lot of them, but we actually are technicians and we actually use the equipment every single day. We've kicked that thing around. We've kicked the mill around. We kicked the scanners around. We know what it can't do. So we're not going to oversell it. We're going to tell you exactly what materials it can do, what technology can be used for what material is best in every kind of indication or solution. And, because we actually use this stuff. And that's the difference. And you've got direct lines to, a
service, yeah.
A 40-year-old prosthodontist. You've got, a direct line to all of our technicians. You're not going through help desk versus customer support. And hopefully you get to some guy who actually maybe have used it. You've got direct access to either a dentist or a lab technician for everything that we sell.
And you didn't ask for it, but I'm going to leave you with a marketing tip. I love your YouTube channel. I'm very impressed. You have 7,000 subscribers on your YouTube channel. But the way to make your YouTube channel explode is if you go into Dental Town and you answer a question, when you hit reply, one of the buttons is YouTube. So if you go to your YouTube video and when you hit share, it'll say copy link or embed. You click the embed, drop that in the YouTube button, and then on Dental Town, when they hit it, it goes right to your YouTube, and then they have a very high conversion to subscribing. So go answer 3 or 4 questions with your YouTube video, and your views will explode. Again, I want to end this thing saying that selfishly, narcissistically just for me, Bruce, you were so instrumental in my career, and I got to tell you, same with Mike Detola. I don't know if you knew this, but we probably saw you like 12 times. I mean, it wasn't like 5 times, 6 times. In some of your classes, it was great because I was trying to get my MAGD and you needed hands-on. And right. I remember one of the guys saying, well, this course, it was the same course you took 3 times in a row. It was yours. And it's like, shit, I needed the hands-on. And every time I retook your hands-on, I learned more and more. But you really 10x'd me. From 87 to 95, I mean, I was hanging on your every word. And to all you kids out there, when you got out of school in 87, I was in Kansas and everything modern was in Los Angeles, UCLA, and the leader of that whole cosmetic California, UCLA bleaching, bonding, veneers was Bruce, the man, Crispin. And you'll always be a legend in my mind. You're definitely a legend in all the baby boomers. So I hope you millennials ask your mom or dad, say, what do you know about this Bruce Crispin guy? And she'll let you know. But Bruce, thank you for all that you've done for me personally. Thank you for all that you've done for dentistry. And it was just an honor to have you on the show today.
Yeah, thanks a lot, Howard. I appreciate the kind words.